Clemmensen, who is ex-president of ACA, also a very well-known interventional cardiologist in Europe, a very leading faculty of European organizations, as well as including ESC, and of course, co-organizers of C3 meeting, is now going to talk about left main. And we're very much looking forward to Peter's excellent presentation today. Peter, thank you very much for taking the time. I know it's late in Germany, but we really are grateful that you were able to spare some time to do this today.
And I'd like also to say hello, Ammar Hadidi. Dr. Ammar is already in also. And yeah, thank you, Ammar, for coming. Yeah.
Well, Raj, thank you very much. And also, Ahmed, thank you very much for the invitation. I do want to just emphasize, I would much rather have met you all in Orlando a couple of months ago. But since that is not possible, you know, let's do what is maybe not second best or third best, but let's go with what we have. So I'm actually going to focus today on PCI, not only in high-risk patients with left main involvement, but actually the patients who present and have acute coronary syndrome, and actually also involvement of the left main. This has been a particular interest of mine over the past few months. So let me see if I can get my disclosures out here. There are.
Can you make a full screen, please?
Can I make a full screen? Sure. Is that better?
Yeah, that's better.
That looks good.
Thank you very much. So I think, you know, when you're talking about patients presenting with acute coronary syndrome and where the left main is involved, you really have the same challenge, but you have two different scenarios. You have the scenario where the left main is involved, but it's actually the non-culprit territory. And then you have the very acute situation where the left main is the culprit. Now, if you look at sort of overall acute coronary syndrome patients and look at completeness of revascularization, there has been some very interesting recent publications. And this is indeed from a meta-analysis of patients, admittedly, including mostly patients with STEMI, but you can see here the big array of patients that were included in these STEMI trials, and looking at the advantages of completeness of reperfusion. You know, I had the pleasure of being in one of the larger of these studies, the Dynamic 3. But overall, if you look at all-cause mortality, there is really little to gain. So this is sobering. Most of the effect when we do this is actually that we do not need, that we avoid a lot of reinfarctions, or quite a substantial number of reinfarctions, and also reinterventions. I don't show the data, but also mind you, in these studies, there is quite a lot of crossover to the other arm. I mean, in these recent trials, in the conservative arms, the patients who are treated conservatively, 30 to 40% actually seems to cross over within the first 6 to 8 months. Looking at the same question now from a large database, a registry with almost 10,000 patients, you see that indeed completeness of revascularization in ACS patient as a whole does seem in this registry to favor complete revascularization with a very highly significant p-value, and almost or about a good 20% decrease in outcomes. So if you look sort of back, I think it is important if we return to the theme of the left main being involved. We actually, if we look at the old unstable angina non-STEMI trials that actually looked about mostly an invasive versus a conservative strategy, because we don't have any recent trials really on this subject, you see that we have to remember that bypass surgery is really not uncommon in these patients. So these if you wish, stabilized acute coronary syndromes presenting as non-STEMI. Bypass surgery in the pivotal FRISK trial was almost 40%, and not that different from the PCI intervention. And if we look some years later at a meta-analysis that Peter Dammen performed, Peter from the Netherlands, you see that 22% of the patients actually had bypass surgery. In more recent STEMI trials, it is less, it's about 15%, and also in STEMI plus shock trials, you see it's still less in more recent years. But what is the prevalence of left main involvement or three vessel disease in patients with ACS? Well, if you look at patients presenting with non-STEMI or STEMI, it's not all that different. You do have some more patients with left main disease in the slightly older and more comorbid burdened non-STEMI population, about 40%. But if you move to a shock scenario, then you will see left main involvement or three vessel disease in about 3/4 of the patients. So we go back to the scenarios. If you look at the left main as a non-culprit territory, really, we have very little data on this subset. And you can see here just a couple of the studies. One registry from Korea found that left main was involved as a non-culprit in less than 2%. And in a pooled analysis of the latest 8 STEMI trials, the prevalence was about 3%. However, these patients have a very poor prognosis with a hazard ratio for mortality of over 2. Here are some of the data from the randomized trials in ACS. Most of these, as you can see to the left, are the well-known STEMI trials. And you can see here that left main was excluded in most of these studies or was very rare, 1% in the culprit study, and in complete, less than 1% of the population with more than 5,000 patients included. So from big trials, we really don't have a lot to go for. Now, the other part of the scenario is when the left main is the culprit. And there I have also taken a couple of examples. One simple case, because we already heard about the balloon pump. But then I'm also going to focus on some recent data that will soon come out from the culprit shock trial, just to share some very new evidence with you. Well, this is a case, complicated case, much like we saw before, in a patient with three vessel disease and a acute coronary syndrome with end-STEMI presentation, but very high troponins. You see here on the right coronary artery is occluded, but not that big. And on the left, you see here, you saw the distal bifurcation, left main stem stenosis. And as you appreciate on the picture to the right and also on the previous slides, you see that we chose to go for a protected PCI using an Impella CP in this patient, actually because it seemed a little complex to go about, to give us some comfort to be able to do this in the time needed in the cath lab. The procedure itself, I'm not going to go into detail. We're going to have cases later on, but you can see here that actually my colleague here chose to do a culotte technique and ending with the kissing. And then this is the final result with the patient leaving the cath lab stable. Whether that was due to the Impella or not, as mentioned, you know, the data are still pending to some extent. So just a few things when you engage in left main PCI and ACS patients, there are just a few tips I think that most adhere to. That is always to have the extra support you gain from an extra support wire. I would like personally to always try, if at all possible, to do a one stent technique to do it fast and smooth if possible. Second choice would be to go for a DK crush technique, and only in cases where I think I really need to go very fast and unequivocally need a 2-stent technique, I would do the culotte in an acute setting. When you do the DK crush, you might want to consider to crush the LAD instead of the circumflex, depending on the angle or the amount of calcification that you have. And I would say we always use a mechanical support system when the patient is unstable or the anatomy is extremely complex and you think you're going to use a lot of dye with multiple dilatations. We always try to place the Impella or the ECMO before the PCI, before things go sour. And then I always consider in these patients who have bad absorption to use Cangrelor IV for stable and acute P2Y12 inhibition. Just a few comments on this. And then I would like to move on actually to show you some data that has not been published yet, but is coming up in JAMA Cardiology from the culprit shock. And I did not, actually, as you can see, this is by Sadan Farhan, who is now at in New York with Holger Thiele and Kurt Huber as the seniors. He looked at the culprit shock trial, including the registry, and looked at the patients with very high risk with shock. Those were the ones where the left main or the proximal LAD was the culprit, and compared these to other culprit lesion locations. And you see a fair number of patients, more than 200, with these very proximal high risk or even left main involvement. Of course, the randomization was very balanced here. And this allows us to get some insight into how these patients may actually fare. You can see in this subgroup analysis how it was defined in red. On the top to the left, you see here what was considered proximal LAD and left main, pretty standard. And you have all the others to the right in the right coronary angiogram. Phantom, you see the other culprit locations. And if you look here at the risk, the relative risk of culprit lesion PCI versus immediate multivessel PCI, you can see here that there are some trends in the interaction when it comes to death here, favoring culprit lesion PCI only, and a lot going in the same trend for the other outcomes as well. You might want to consider or remember that the original primary endpoint of the trial was death or renal replacement therapy. Also here seems to favor, as also in the main trial, the culprit lesion only PCI. However, proof of concept, if you wish, certainly the patients with occlusion or culprit of the left main or the proximal LAD compared to other lesion locations had a higher mortality, death from any cause at 1 year, with a significant p-value and almost an absolute 10% difference in mortality. And now comes here really the highlight of this sub-study. Here, if you look at the importance of treating the left main or the proximal LAD only compared to multivessel PCI when the left main is the culprit, you see here in blue how it turns out. The blue curve here is multivessel PCI, where the culprit lesion is the left main or the LAD. This really has a quite excessive mortality after 1 year, whereas you can do pretty much what you want to do in terms of coronary interventions in the rest of the population, with not much different whether you do culprit only or multivessel PCI immediately. So this is sort of to sum up things. If you have an acute coronary syndrome and multivessel disease, in the non-STEMI population is really a no-brainer. We have the proof. You should do the culprit immediately. Likewise, in STEMI, you do the culprit immediately, and the same actually for acute coronary syndromes with cardiogenic shock. The null culprit, you can do immediately in NSTEMI. I think we have the proof now, or you can defer it, but also you should use a physiology guide way to go about it. The same for STEMI. There is one study, the multi-stars, that is currently enrolling, comparing complete revascularization in all STEMI patients, but randomized to immediately angiographically guided on the table in the middle of the night versus deferred after 19 to 45 days. So we might get some more insight to the STEMI population, but for cardiogenic shock patients, it's really different. There, the non-culprit lesion PCI should really be deferred. Do culprit only, especially if the culprit is the left main or the LAD. Then you just do that lesion and leave the rest alone and try to get out of there and get some sleep. CABG bypass should not be forgotten. It is still an option and was an option in many of these trials. And I think that is still a good option if you have surgeons around the corner. And with that statement, I would like to also conclude from the ACC sort of guidelines or the appropriateness of revascularization when it comes to high-risk interventions in patients with acute coronary syndrome and left main involvement. I think you, as with a level of evidence or a recommendation 2A, level of evidence B, for NSTEMI, you can do PCI and multivessel PCI if the patient is not a CABG candidate. For STEMI, if you have less than TIMI-3 flow, PCI should be performed if it's rapid and safe compared to CABG. And with that, I have added here with some big letters, you should really only engage in bypass surgery if you can do this swiftly within 6 hours of symptoms in patients with acute coronary syndromes and ongoing ischemia. If not, you really have a very bad outcome. So these were, thank you very much for your attention.
Thank you very much, Peter, for this outstanding presentation. And I would appreciate very much if all the previous and this lecture, if you can send it to me, because a lot of, we have our archive system and we have presentations that will be asked by the fellows who are sharing this event. If you can send these lectures to us, and then this would be useful. So if any comment from, yes, Amin, how's تكلم, Amin? This lecture, if you can send, Amin?
Unmute, Dr. Amin, unmute.
Unmute, Amin.
Thank you, Professor Peter, for this very illustrative presentation of left main bifurcational lesion. But as we all learned that the incidence of restenosis in the side branch, when we are concerning about talking about a bifurcational lesion, we have a 20 to 30% or even higher percentage of restenosis in the side branch rather than in the main vessel.
Yours,
yes. In your you speak about crushing the stent in the LAD. So we always do our effort to crush the stent in the LCX, and then we make the LAD at the main vessel. So when you consider crushing the stent in the LAD, and especially in patients with a STEMI or shock patient, we're always in a hurry of putting the stent in the LAD. So my question, when you consider crushing the stent in the LAD and consider the LAD as a side branch?
This is, I can't see my microphone now. Can you hear me?
Yes, I hear you very well.
Good. Well, sometimes since the preferred strategy for these patients in our hospital is actually to do the DK crush.
Yes.
Sometimes when you do that, you do have, when you cross a very angulated circumflex, then which is also calcified, you really sometimes have to struggle not only to rewire after the crushing, but also to get the balloons in to do the first kissing. and to reopen the struts. So this would be a case where I would crush the LAD. When I do, I just, I make sure that I do a very effective kissing afterwards, whether very aggressive. And as you know, according to the European guidelines, you do have the freedom to go back, and actually it's a 2B indication, but you actually can take the patient back in 6 months and do an angiogram and see if you have one of these soles that do a lot of restenosis at the place of the crush.
Okay. Dr. Peter, can I have a question, Dr. Ahmed?
Yes, Ayman.
Dr. Peter Amr Al-Hadidi from Egypt. How are you? It's a very excellent presentation as usual, Dr. Peter. I would like to ask you the percentage of cases that you are using IVUS in left main, especially in left main. The percentage, is it mandatory for you to do, especially if a complex cases, calcified lesions?
The short answer is yes. And then I'm embarrassed to say that I struggled 2 days ago. I actually did not do one in a female patient where I was sure that the not only the stent size at 4.0 and the post dilatation when making the flare and the ostium with a 4.5 was really oversized, and then we actually deferred from doing it. But yes, routinely, I think this is, we always do an IVUS in these patients.
So we need to emphasize that doing left main intervention in the setting of acute coronary syndrome is not like elective cases. You need to save the patient. You need to you have time managements, and you need to save the myocardium, and you need to be less sophisticated and to reduce the manipulations as much as you can in order to save the myocardium in a timely fashion. So without further ado, we thank Peter for his outstanding presentation. Then Professor Adil Atribi will introduce the next speaker.
I would like to thank Dr. Peter for the excellent presentation. Actually, the next lecture is a stage, a different stage with heart failure, and it gives me a great pleasure to introduce Professor Mohamed Seleem, consultant cardiology at National Heart Institute and the head of the continuous medical education in National Institute, and also the secretary of the working group of intervention. He will be talking about heart failure being still a challenge.
Thank you, Professor Adil. And also